So at this point, we're going to have both Dr. Brilakis and Dr. Banerjee discuss for us the issue of access during both diagnostic as well as interventional cardiology procedures. And as we all know, radial access has become sort of the in vogue thing. A lot of that due to what's been developed at our institution at the VA. So at this point, I'll turn it over to the chief of our department, Dr. Banerjee.
Thank you very much. While they pull up the slides, welcome all once again. And for those who have trickled in during the first session, I hope you're enjoying these fabulous presentations from national and international faculty. I also want to say that all of these presentations have been preloaded at the dallascvi.com website. So you go onto the agenda, all the presentations have been hyperlinked, and all the PDFs of this presentation have already been uploaded, and a video of each of these presentations will be uploaded after the end of the conference. This is a topic I and Manas have been debating for the last 3 years, from Dallas CVI when it started 3 years ago. The debate ensues, and I can tell you that we are coming towards the end of the debate, and let me make a forceful start and then putting him on the back seat because he gave me the chance to go first. So, Radial for all. Here are my disclosures. What is radial PCI? You know, cardiac catheterization and stent implantation or percutaneous coronary intervention or PCI can be performed through the groin as shown on the figure, or through an artery in the wrist just at the base of your thumb, which is called the radial artery, which involves 3 primary principal steps. You make an arterial puncture, you then insert a plastic tube, which is called a sheath, and then after the procedure is over, you remove the sheath and put a plastic tape on it, which is called patent hemostasis. That's basically what we are debating about. Should we use the groin or the hand? I'm for the hand. Before we jump, why is this debate important? Why is this an esoteric question? Why are we wasting your time? The real issue is that bleeding during heart procedures, which was considered to be a minor complication for many decades, is not really a minor complication. This study actually shows the outcomes of death, myocardial infarction, and stroke in patients who actually bleed. Think about it. You implant a stent, you give a patient blood thinners, the patient bleeds, you stop the blood thinner, the stent thromboses or has a clot, and the patient has a second heart attack. So it is not inconsequential how we approach our procedures. The first study I want to show you is called the Radial study, and in this study, the outcomes of this study are shown here. There was a reduction in major vascular complications with the radial access, and there was a statistically significant reduction in bleeding in terms of patients who had the radial access. However, as my partner might suggest, there was no difference in outcomes of death or heart attacks or strokes, which expectedly were not supposed to be different just by changing the axis. In terms of patients' preference for the procedure, I've highlighted that in yellow. All the other outcomes are shown in white. But look at the difference in a patient's preference after the procedure. 90% favored that if they ever have to come back, they would like to have the radial approach versus 50. And if we are a patient-centric, physicians and patient-centric hospitals, we really have to take this into close consideration. Another study which I want to cite in the few minutes I have is the Rifle STAS ACS study, in which bleeding onto the right of the screen, major adverse cardiovascular events or MACCE, cardiologists love abbreviations, and onto the extreme left is net adverse cardiovascular events or NACE, which is a composite of cardiovascular events and bleeding. All were statistically significantly reduced with the radial access and using the wrist artery. As you can see, there was a 47% reduction in access site bleeding by using the radial approach. Many have contested that the radial access is only for men. As a married man, I can tell you nothing is for men. The arterial dimensions of men and women are shown on this plot. And recently, one of our colleagues, Dr. Sunil Rao, did a study of testing the feasibility of radial access in women. And the study was halted prematurely because the complications of both femoral and radial accesses were extremely low, as shown on the slide, 1.2% and 2.9%, which did conclude that radial access can be done safely in women. Radial catheterization sometimes poses some technical challenges. If the arteries are taking off in a severe angle, we have to use multiple different kinds of catheters, and sometimes we have to change and interchange catheters. The industry, and many of them are here presenting today, their products, have provided us with a lot of options in terms of larger caliber with thinner walled catheters that allow us to deliver more and more intracoronary devices through a radial sheath. And another point I want to point out that according to the SCAI, or Society of Coronary Angiographers and Interventionalists, if one needs to be proficient in radial PCI, they need to perform at least 30 such procedures a year, 40% of their overall volume, with a success rate which grows over time to above 95%, then they can be proficient at performing radial PCIs during acute coronary events. Some common sense measures apart from radial access can also reduce bleeding complications, and I've shown them here. But one point I want to show is the second last point, that by doing radial procedures, operators become inherently more conscious about bleeding and access, and they become better femoral procedures. So hopefully this will be a lesson for my honorable colleague who will follow me next. Why don't people use radial procedures? There are three main reasons published in heart.org. 32% of patients demonstrate a lack of knowledge and training. Sometimes they don't want to do it for complex procedures. And then others, a third, who are not comfortable with it. Let me tell you, I know my partner for the last decade. My partner neither lacks the knowledge, skill, conviction, or awareness of current evidence, as you've seen. During this debate, while attempting to articulate a point of view that is at the fringes of current practice standards, I'm confident that my esteemed colleague will finally convince himself of the futility of this debate, will switch to an all-radial approach, and propose to scrap this debate from the next Dallas CVI agenda. Because the video doesn't have an audio, this is a silent endorsement from Dr. Brilakis to what I've just said, and this would be a perfect segue for him to take on this presentation and continue. Welcome, Dr. Brilakis.
Well, that was an excellent introduction. Now you see how things work. When we don't like what do I say, then it's silent. It's a well-time-tested strategy. However, I think the word is not out, and I think it's only fair to put the evidence to you so you can decide, what is the best way to go. Because, everyone has biases, and I have biases too, but probably a little less. So I'm going to show you some of the data and let you decide what you think is what we need to do. Should we do radial for everyone or not? Okay, I can't show Dr. Banerjee's slides again. I think you've seen them. Let me actually say one thing that wasn't mentioned, that Dr. Mixon, I just spoke, he's actually the director. He puts together the Texas STEMI meeting, which is a very robust and very important meeting that happens every year in a different city in Texas. And any of you with interest in STEMI, I would strongly encourage you to participate, because it's a really unique meeting, and I think there's a lot of things to be learned from that. All right, so the title was Radial for All, but the better title is this. It's Radial for all who want to suffer. Because, as I'll show you down the line, there's a lot of suffering involved. I'm not sure it's communicated well in the presentation, but I'll make sure I convey this to you. So, there are several things in life that appear very promising. We're all looking for a cure-all. Something you're going to take, and it's going to make you cure any ailment you have, make you feel the best, increase your productivity. This is an example. For those of you who need something like this, it's here. You get lemon juice, ginger juice, and garlic, and apple cider vinegar, put it together, make sure you leave it for 5 days, and that's going to cure everything. So, and the reason I'm showing this to you is because that's how radial is presented. You do radial, and then it's cure everything. This is the best thing on the planet, let's do it, everyone's going to be safe. As he said, yes, you cut vascular access complications. That's a good thing, starting point, there's no question about that. However, there are some actually real-life cases. So this is a case we had a few years ago. It's a vein graft. You see a nice blockage here. Seems to be a quick case. We're radial. Let's go. And after 55 minutes of fluoro, which again, we were young and enthusiastic, we finally switched to femoral. And it was a good thing we did that because after doing that, then we're done in 5 minutes. So, yes, radial is great, but sometimes there's some practical limitations, and not along to mention how much radiation the patient got and we got. Anyway, so there's a price to be paid. There's nothing free in this life. There's a price for everything. And radial is not free. It comes with a heavy price tag. I'm going to show you some of the price tags. So number one, it's harder to engage the vessels. Number two, less support. Number three, you have smaller catheters and fewer things to do. We actually did a randomized trial on this, just published, that got heavily criticized by the radial evangelists because it doesn't show what they want to show. But that's the data. And this was a study we actually randomized 128 patients with previous bypass. The question was, does previous bypass patients can go radial or femoral and is the same or different? What we found is, first of all, that if you try to go radial, 17% of the time you have to switch to femoral. So starting off the bat, 1 in 5 or so are going to have to be switched. Number two, you use more contrast, you use more radiation for the patient, more radiation for you, and the whole thing is very painful. So clearly it's not the same. I mean, you may choose to do it if you would like to suffer and get more radiation, but clearly there's some differences there. Now, what does it matter? Radiation doesn't matter. I think I alluded to it earlier on. Radiation has some price to it. And what is the price of radiation? And I think the whole point of this, I'm not doing this to be nasty, it's an act of love for my colleague. So I don't want him to become blind. Radiation is bad. The more radiation you get, you cannot see. Interventional is blind, not a good thing, obviously. Second thing, you can get cancer. I mean, more radiation you can get more cancer. You get radial all the time, you're going to blast your radiation, then you want him to be around for a long, long time, at least 30, 40, 50 years. Third, this is one of our fellows. I got permission from him. This is how the radial works. You can see him. He's like this. Now you tell me, is this good for his spine? He didn't think so. I don't think so either. And again, we don't want to get over there. Jokes apart, at Mayo Clinic, half the interventional group have got some sort of spinal surgery, spinal fusion, some major operations. Wearing this lead for a long time is not good for you. And again, if you're going to wear it for even longer than you have to, that's your choice, of course. Now, this was going to show you an important element, hidden secret weapon of Dr. Banerjee. He is wearing this very heavy gold ring. So that gives him extra protection. Unfortunately, it's only for the finger. So it's not going to help for the rest. But there's a starting point. And then, this is Don Hagen's, our cath lab manager's favorite point. This is what happens when you do radial. Your garbage basket fills up very fast because you're going to use a lot of equipment. So I know price is not always the number one thing, but Don doesn't think so. So more time, more contrast, more catheters, more dollars. Also, it's an issue of how well you would like your coronary angiogram to be. Doing femoral, you get good engagement, good pictures. So would you like your interventionalist to look at these pictures or at these pictures in the bottom? Again, the patient likes radial, but the patient doesn't know that you want to get good pictures because at the end of the day, it's nice to be comfortable, but if the job is not done, then that's a problem. So, and then that other question is, if you have this complex anatomy, if you have a left main intervention, you have some complex anatomy, would you like to go femoral or radial? And then even if you're a patient, you would like to go femoral, I would like to go femoral for these complex interventions. CTO is a classic example. Complex vein graft is a classic example. I saw you a case. Left mains, anything complex. I think there's no reason to suffer. You do it much faster and actually safer by doing it femoral than not. And then if something goes wrong, you have many more options to be successfully treating that if you go femoral than if you go radial. So I think what we are now, we're at this stage, we're at the peak of the hype of the radial revolution. Radial is good, everything comes out, everyone gets very excited about it, it gets very high, and then finally people realize that, it's not what we thought. It's not a cure at all. So things bottom out, and then finally there is a balance. I'm afraid we're actually up here. And to finalize, it's not just me. So this is the reaction of the cath lab. This is one of our technicians, Dwayne Williams. This is his response after he found out that our fellow tester randomized the patient to radial. And that's not only him, that's the only one who accepted to be in the picture. Everyone in the cath lab was going like this. So I think people have spoken. I think you're right, we should scrap it from next year's because, there's no point. Femoral is the way to go for many of the cases. So thank you very much.